Hello and welcome to Health on the Line. I'm Daniel Reynolds, Director of Communications at the NHS Confederation. Coming up shortly, our Chief Executive Matthew Taylor talks to Paul Mears, an experienced NHS leader who has worked in both the English and now Welsh health systems, about how to deliver better integrated health and care, drawing on his experiences of both systems. But first, I'm delighted to be joined by Chris Thomas from the Institute for Public Policy Research, the IPPR, who's going to talk to us about a new report that the NHS Confederation and IPPR have just published on the role of the NHS in supporting social and economic development. As part of its mission-driven approach, the new government has been explicit about how it sees the NHS as an engine of economic growth. In fact, in one of Wes Streeting's first speeches since he became Secretary of State, he made clear that the Department of Health and Social Care is an economic growth department, saying that the health of the nation and the health of the economy are inextricably linked. This has been a major focus of the IPPR's Commission on Health and Prosperity, which is a landmark cross-party initiative that explores the links between health and prosperity. As part of the Commission, my colleagues at the Confed have worked with Chris and the IPPR to engage with integrated care systems in England and a health board in Wales to understand the practical changes that local systems can make to deliver on this agenda. Their new report, published a few days ago, is a great read, and we'll share the link in the show notes. As head of the IPPR's Commission and co-author of our new report, Chris is here to tell us more. Chris, welcome.
Hi, Daniel. Thanks for having me.
So, Chris, can we start with your assessment of the government's ambitions in this area? As you know, organisations like the Confed and IPPR have long been making the case for the NHS to be regarded as a key driver of economic activity and not to be seen as a drain on scarce public resources. But from what you've heard from Wes Streeting and other ministers so far, how confident are you that the new government will grip this agenda?
Yeah, really good question. Very, very encouraged is the answers. So I think it always bears repeating the size of the challenge, right? The assessment we have at the moment of the UK, and I'm sure this is similar for NHS Confederation, is that we really are the sick man of Europe. A lot of our outcomes are flashing red and they're behind other comparable countries. And then the damage that's doing to the economy is very profound. One of the clearest ways that happens is that if someone's unwell, they can't get the support they need, they're on a waiting list for a long time, they don't have the support then they need in their work as well, then they probably fall out the labour market. If they fall out the labour market, then we know that's one of the biggest drags on economic growth that exists at the moment. And then in turn, if there isn't growth, then much harder to invest in public services. And so that vicious circle kind of turns. But the encouraging news really is that seems to have been recognised as an argument. Look, there was some encouraging news even before the election from my point of view that we had organisations, really important economic institutions like the OBR, the IMF, the Bank of England, all of them talking about the importance of health and suggesting that the UK needed to prioritise this. We've seen in the first days of the new government, Wes Streeting talk about the Department of Health and Social Care as an economic growth department. I think that's very encouraging, and they're beginning to flesh out now what that looks like. So we have the foundations, I think, for this kind of link between health and the economy to be understood, for that to start to mean that we see health as an investment, just as something we can only spend money on when the sun is shining and the economy is good, as a luxury item, basically. We'll see it as a necessity, and that would be really good. And obviously now the test of that aspiration is the extent to which, one, that has follow through. We'll be looking to things like fiscal events, but two, the extent to which government follow through on their promise and give others, including systems, the tools to begin to act on some of this and to deliver prosperity in their own places, in their own ways. We'll hope to see more on that in the months and years to come.
I do feel for colleagues like you and my colleague here at the Confed, Michael Wood, your time has come, because I know you've been making the case for this for many, many years. So I think the kind of change in rhetoric and approach from the government's very welcome in this area. As you know, we've conducted our own analysis with Carnel Farrer, on the clear return on investment for the wider economy that you get when you invest in healthcare. So, Chris, what do you see as the potential for the NHS and in particular integrated care systems in driving economic growth?
Yeah, huge potential. So worth me saying the work with Confarra, the NHS Confederation have done is very impressive, and I think makes the point very powerfully that if we invest properly in the NHS, then we get returns on that investment, and that if we do that strategically, i.e. we think about things like investing particularly in primary care, community care, general practice, then we get even better outcomes. So that's a really good foundation of evidence to go from. I mean, I think there are a few big channels for the NHS and ICSs to think about, many of which the ICSs are incredibly well placed to prioritise. There's obviously huge promise in prevention. One of the things that I think is underpinning the fact that at the moment we have this kind of high and rising rate of economic inactivity due to sickness isn't just the pressure on the NHS. It's also that there's been this kind of failure to do prevention over a long period of time, partly about public health and population health as an agenda. But of course, ICSs should be brilliantly placed and a really important system to get some of that moving in the right direction. But the other place that I think is really important is the ability that the NHS has to work with employment services and with the work agenda to create new care models and to bring those two things in a more integrated way together. Some of the most exciting initiatives I can see in the NHS are those where, say in South London and Maudsley, where they're thinking through very carefully how to bring employment services into primary care, in Glasgow, where they're thinking about how to make sure that employment and finance are a key part of how the NHS approaches people after a diagnosis, in that case a cancer diagnosis, and how they bring partners in to support that process. How in Leeds they've been thinking differently about how they upskill people to make sure that when they come to recruit through anchor institutions, that people have proactively been kind of upskilled in a way that makes jobs in the NHS and other public services possible. So those are some big opportunities. Treatment, yes. Prevention, definitely. But also just different ways of thinking about what the NHS can do with others in partnership as an employer, as an anchor. These are all really exciting ways that Health and Prosperity gives us ways to get into different ways of working, I think.
I think it's one of the best things about the report. You talk through local areas that are making some really practical changes. You also talk about what are the key guiding principles for local systems to follow. I think there's 6 of them that you talk through. So can you just give the listeners a bit of a flavour of what those principles are, please, Chris?
Yeah, of course. So, Daniel, I won't try to test my memory and list all 6, but I'll give some of the ones that feel really important. So, of course, they're all important. I mean, the core premise of the principles that we set out, and this was interesting because it's a hypothesis we genuinely tested in the research that sits behind this report. But the things we set out are basically that structures and governance do not a successful integrated care system make on their own. I think listeners will intuitively understand that, right? I think it's brilliant that ICSs have statutory footing. It's a big opportunity, but just the creation of integrated care systems is not enough in its own right. Some act of parliament doesn't make the theoretical promise that they have, become reality. So our principles are really all about what do we need to do beyond structure, beyond process, beyond governance that will really make a difference. And I think some that feel particularly critical to me, particularly given some of the case studies I've just talked about, are that the ICP needs to be a really central partnership driving forum in a way that, kind of means giving it some clout. We talk about starting with what's strong, and that's really a message that every place that we went to and talked to had strengths, massive strengths, and that employing those can be really, really effective. We also talk about building those strengths, and that the NHS has a role as a, kind of big institution in lots of places of investing in strengths and making sure that thriving, population health ecosystem is there, whether that's, working with VCSOs or charities or others within the system. Sharing resources and particularly linking to communities, getting ideas from communities. We can often think of the NHS as very top-down. Idea goes from centre to system to place. some of the best things systems are doing are reversing that, starting with communities and engaging their communities really effectively. And cultural change, that lots of system working needs a different way of thinking that is perhaps not that similar to the kind of bedpan in Tredegar vision of the NHS from 1948, and the best ICSs thinking very carefully, or there are brilliant examples of ICSs thinking very carefully about how to do that cultural change.
I think that leads brilliantly to the last question, Chris, really, because we know the government has a big devolution agenda, and we really hope there will genuinely be opportunities for local systems to take on more control and more autonomy. But it won't surprise our listeners when I say that governments of, all political persuasions in the last 25, 30 years haven't done enough to empower local leaders in that way. So do you think this government will be able to hand down the right amount of autonomy and control for local systems to really deliver on this agenda? And if so, how best for them to do that?
Yeah, I mean, lots of people will have been burnt before, right? More devolution, more autonomy at a place or a system or a local level has been a feature of the kind of rhetoric of reform plans for a long time across different governments, and it hasn't always actually followed through. So I totally agree. I mean, there are some indications for me that this time may be different. The proof is always in the pudding, but the fact that the mayors have been very heavily involved in the new government's thinking, and there seem to be some kind of formal mechanisms for that involvement, seems to me very encouraging. Obviously, not everywhere has a mayor, but often mayors can provide the test bed for kind of the devolution process that then gets spread elsewhere. So I think that is encouraging. The other one is that my understanding of mission working, and I think the kind of latest ways that mission working is being thought about, genuinely demands the kind of devolution and empowerment of others that we're talking about. The best mission thinking, where people like Marion and Mazzucato are at the moment, is that it has to be driven by bottom-up solutions, bottom-up innovation, and that's the difference between kind of modern mission theory and the kind of missions that put a man on the moon, kind of NASA going it alone. And if the government are really serious, which all indications are, about embedding missions as a way of doing government, then they'll need to make sure that this is, devolution is a critical part of how they do that, and that others have the resources, the capacity, the permission, the ideas they need to contribute to that bottom up, as I say. So we will obviously at IPPR, and I'm sure at NHS Confederation, be strongly holding the kind of accountability on that and making sure and looking to make sure it does happen. But I think there are some good indications that it will, or that there are plans to do so, and we hope to see that. Very important that it does, and that has follow through.
Yeah, no, I agree. And certainly ahead of the government's new 10-year strategy on health that we'll be contributing to, that's certainly going to be a strong message that we'll be pushing to really empower local areas and systems to take this forward. So I think that's a great way to conclude the interview. Thanks ever so much, Chris, for coming on to Health on the Line. As I say, listeners can access the report through the link in the show notes, so please do read it when you can. That's it from me for now. So over to Matthew Taylor for his interview with Paul Mears. Thank you.
We're now 2 years on from the formal establishment of integrated care systems in England. ICSs, which are partnerships bringing together health and other organisations in local areas, were born into a challenging context. It's fair to say it's been far from plain sailing since. Political and economic uncertainty, hefty reductions to running cost allowances, rising inflation, cost of living crisis, industrial action, all of these factors have created a set of challenging circumstances. But many ICSs are now starting to flourish. For the NHS in the devolved nations, structural integration of this kind is, however, not new. So with ICSs at a crucial stage in their development, I wanted in this episode of Health on the Line to take soundings from someone further along the integration journey to see what more the English system can learn. So for this discussion, I'm delighted to be joined by Paul Mears. Paul is Chief Executive of Cwmtaf Morgannwg Health Board in Wales and was previously Chief Executive of Yeovil District Hospital in Somerset. Paul's a long-standing integrated care enthusiast, an advocate, an innovator. He is well known for establishing the Symphony programme while CEO at Yeovil. That programme is a primary and acute care system vanguard, integrated care across primary care at the acute hospital and community services. And it also prompted the establishment of Symphony Healthcare Services, a primary care subsidiary company of Yeovil District Hospital, which operates 12 practices within South Somerset. In fact, I visited Symphony just the other week. Paul started his NHS career in Torbay, where he was instrumental in setting up Torbay Care Trust and leading the operational business of one of the first integrated community health and social care organisations in England, as well as working as Chief Operating Officer at Torbay Hospital. Equally passionate about innovation, Paul is the National Chief Executive Lead for Innovation in the Welsh NHS. And he also leads the delivery of value-based healthcare across the country and sits on the management committee of the Welsh NHS Confederation. Paul, welcome to Health on the Line.
Hello, Matthew. Nice to be here.
How are things with you at the moment?
Well, like everybody, wrestling with some significant challenges, waiting to see what the future change of UK government brings. And obviously, particularly interesting for us, whilst health has evolved in Wales, it's interesting to understand what any potential change of colour of government in UK government might bring in terms of the interfacing with the Welsh Labour government. So lots of uncertainties in the sort of macro system around us, but some interesting and innovative things going on in my own organisation. So despite those challenges, I'm very optimistic, actually, at the moment.
Well, that's good. That's good to hear. So Paul, there can be very few people who have thought more about and practiced more in the area of integration. So I want us to get right down to kind of the basics here. What do you understand by the concept of integration, and what is it fundamentally that we're trying to achieve when we talk about it?
So that's really interesting starting point, because I think the first thing to say is what integration isn't, and it isn't, in my view, organisation structures and processes. I think that's an enabler to providing good integrated care, but actually the most important thing is that you are enabled to bring together the right professionals to support the people in our communities when they most need our services, and that we try to bring together the right interfaces for those individuals. And I think for me, throughout my career, and you mentioned there a number of the areas I've worked in over the years where integration has been sort of an underpinning philosophy of what we've done, it's more about an ethos, a mindset, an approach, supported where necessary by structure, but not designed in structure. And I think that's a really interesting and important point to make, particularly in the context of some of the things that have gone on in Wales. And it's not just having structure of integrated services that brings everything together in one place that delivers better integrated fair care for the individual. It's actually an ethos and philosophy that underpins all of the clinical behaviours and processes. For me, that's the most important thing, which drives better care for population.
And what's at the heart of that philosophy? And I'll share with you, Paul, something that I said. It's a rather pompous thing to do, I'm afraid, but I've reached the age where pomposity comes naturally to me. I'm going to quote myself. In my Confed Expo speech a few weeks ago, I talked about the concept of flow. And I said that I thought it was intriguing that we talk a lot about the notion of flow in the health service, because it betrays something. Because when we talk about flow, we mean the way patients flow around the kind of fixed banks and rocks of the health service. And that it's interesting because really shouldn't our ambition be that services flow around the needs of individuals? So is the heart of the philosophy of integration the idea that services need to be built around the needs of people rather than people having to navigate their way themselves around the organisational architecture?
Yeah, I absolutely agree with you. I think the NHS has a preoccupation with organisational design being the answer to problems. And as you rightly say, and it was very much underpinned with the work I did in Somerset, actually, it was to say a one-size-fits-all NHS won't work for everyone, right? So there will be some people who need a very straightforward, simple service because they've just got an individual issue, transactional sort of relationship with a professional that just needs sorting and they can go off and deal with it. Integration is not needed for every patient. Where people need integration is where perhaps they've got a complex need, or they've got a pathway that needs sort of a number of people to be involved in that process. And we need to try and make, as you say, the process that underpins that care as streamlined as possible around the needs of the individual. And that could be a 55-year-old man dealing with prostate cancer needing to have really good care coordination of all the various stages of his treatment journey, or it could be the frail elderly lady who's in their 90s with multiple comorbidities, living in a very precarious home situation, who needs a very vast array of services supporting her in her own home. I think when we talk also about integrated care, people sort of think it's straight away we're into frail elderly conversation. And of course, there is a very great deal of that need for frail elders, but there are also a lot of younger adults who need integrated care. When I did my work in Somerset, we were quite surprised at the number of people who were under 65 who had high needs, who were high users of health and care services because they were complex diabetics, they might have had drug and alcohol problems, they might all sorts of people. So integrated care is, as you say, it's a range of services that fit around the individual needs of the population, but are designed to meet particular segments of our population. And I think for me, that's been one of the things I've learned over the years, is trying to design a one-size-fits-all model really won't work, because you think about any other industry, what do? You segment your market, you design products to meet the markets that you're trying to serve, you design service models for those populations, you have different interactions and communication methods for those different populations with client or customer groups. Historically in NHS, we've had a relatively one-size-fits-all model of care that has been deployed. So for me, that's very much underpinning, as you described, what we should be doing is design with service models around individual needs of the population.
So, Paul, why is it? No, I was going to say, why is it so difficult? But I'm going to be harsher than that. Why are we so bad at it? Our patient group has changed dramatically, hasn't it, over the last 30 years? I did a Channel 4 news conversation recently about there's a dispatches expose of very bad treatment in an A&E hospital in Shrewsbury. And watching the programme, the thing that really hit me about the programme was, on the one hand, the complexity of the needs of people coming into that A&E department. 30 years ago, I think 3/4 of people who went to A&E departments went with an injury. And now, roughly that proportion are going with the flare-ups of long-term conditions. So one thing that hits you is how more complex that is. Dealing with somebody who's got dementia as well as other conditions is so much more difficult and complex than, I don't know, repairing a sprained wrist or something. On the other hand, so many of those people who were there didn't look as though they really needed to be an ED. I don't mean that in the sense that their needs were trivial. They had got to an emergency point, but you felt that so many of those people didn't needed to have got to that point had we built care more effectively around them, had we been more proactive, had they been given the kind of continuity of care that they needed. So it often feels to me as though the demand that we're meeting in the health service has fundamentally changed over the last 30 years, but the way in which we deliver healthcare is still quite a long way behind.
No, I agree. I think your example there is really, so we talk about one-size-fits-all model in the urgent care world. I mean, we have a one-size-fits-all model in A&E, don't we? Basically, you could have anybody from having a serious cardiac event or a stroke or a major head injury, trauma, whatever, right through to someone who's got a finger that's a bit iffy. And my perspective on that is, I think we haven't designed the out-of-hospital care system effectively enough to divert people away from the front door. I talk to the clinicians in my hospitals, and they would say 30 to 40% of what actually they see in an ED really needs but only ED clinicians. The rest of it could be dealt with in a different way by other professionals or other specialties. Yet we have a model at the moment where if you can't get an appointment with a GP, what's the only other place that's open 24/7 where you're going to get support or help with the ED department? So unless we can provide alternative models to that, we are always going to see it's perpetually increasing demand as people's demands and expectations for instant answers to a problem are ever greater. I think we live in a world now, don't we, where people are used to being able to get anything at the touch of a phone. Within 10 seconds, they get an answer to something. Yet we had a model. I've got a 23-year-old daughter, and she says, "Well, why do I have to wait 10 days to get an appointment at my GP practice to see them about a dermatology issue?" And we can't provide that responsive service that people need. So the answer at the moment is everyone rolls into the A&E department. So I think we haven't really stopped to think about the different segments of our population and what their particular needs are. I think the needs, for example, of frail older people who deteriorate, need, when their comorbidities exacerbate and get worse, they should not be going into a busy ED department. Well, ideally, they should have been looked after in their own home as much as possible. Could we be developing more community-based models for sort of short stay interventions for older people needing IV antibiotics, or a bit of a geriatric assessment that's needed to be done? Does that need to be done in a busy ED or a busy acute hospital? Probably not. It probably could be done in a different model. So we've not really disrupted the model of care, Matthew. I think what we've done is incrementally add to historic models and historic design of services. And I think my perspective on things like hospitals is I really think we've got to question what is a future model of a hospital in the next 20, 30, 40 years. With the demographic changes we're seeing, we can't just think that hospitals are going to become an ever-increasing, growing place where we just warehouse, frankly, frail older people at the expense of people who then really do need acute care. And I think we've got to challenge ourselves to say, well, how could that look different? And the whole out-of-hospital space, if we're really honest, is still pretty underdeveloped in terms of alternatives to ED. We don't have services that run 15 hours a day, 18 hours a day, 7 days a week in community services and primary care that provide a really solid alternative to going into ED. I think we've got to start to think about that, because unless you've got those alternative provisions, back to your earlier point, designed around the individual, the people would always default to the easiest thing, which is to phone 911, and off they go in an ambulance into a hospital and go through that really torturous journey that many of our frail older people at the moment are going through, then being stuck in hospital beds and not being able to get home. So, I think I started my career in community services, so I've always had a bit of a passion for out-of-hospital and community care. And if we're honest, I just don't think the community out-of-hospital space gets the airtime and priority that you do. I think it's everywhere. It's not just in England. I think I experience the same thing in Wales. So I think for me that has got to be part of where we focus our time and energy moving forward.
Yeah, it's interesting, Paul, that you say that. I have exactly the same mind, and indeed that's why we organised last year our first Health Beyond the Hospital conference, which we're doing again, I think, next year, because we really thought it was important to bring together the various sectors, including the acute sector, to focus specifically on care out of hospitals. But I take your point, Paul, that you made earlier on about the fact that integration is around philosophy. It's around our commitment to care that's built around the needs of the individual. But one of the things that's fascinating about you is that you have operated and been an innovator in relation to a whole number of different institutional forms. And so I'm fascinated to hear, Paul, from you. What have you learnt on that journey? Have you come to the strong view that, it's good for acute and community services to be in the same organisation? Or have you come to a view about how we get the primary, secondary interface right? Or are there things about the system in Wales which you think we ought to learn from in England? So there must be some institutional predispositions that you've developed over the years, Paul.
Absolutely. So my time in England, I spent a lot of my time navigating across systems, right? So the torturous processes you have to go through if you're an acute hospital chief executive, trying to work with your community services provider to help get them to design things that you think are what's needed to get people out of hospital, for example. When I worked in Torbay in health and social care, working with local authorities to try and sort of come together and get social care to align with some of the priorities in NHS. And that's always a challenge, isn't it? Everybody experiences that challenge of trying to gently negotiate, carefully sort of construct conversations and structures around partnership working. And so often I think in the NHS that's built on individuals, so frankly, where success has happened, I think historically it's been driven by individual people who've led organisations or led programmes. Candidly, when they leave, often that process falls away, even if you've created an organisational structure, right? It can often be the case that some of that all melts away. So there is something in my head I've learned all the way about leadership, sustainability of things beyond one person. I think that's a really important thing to think about. It can't just be about historic, a new model's built around a person, they're leaving, it disappears. When I got approached about this role in Wales, I have to say that I looked at it and there was a bit of me, it was a bit apprehensive, because I thought, well, the Welsh system is not necessarily always where it needs to be in terms of priorities and performance. But equally, the one thing that really did attract me was the fact that the structures in Wales are, as you know, completely integrated. So as a chief executive of a health board, I have acute hospital services, community services, mental health services, public health services, and all the commissioning responsibilities for primary care in its broader sense. So then dental, optometry, pharmacy, and primary care. So all the levers, effectively, for me, in a way, it's the nirvana, right? It's all the things I've always wanted to do all in one place, and the ability to make the best decisions for your population. So I really excited, and that's what excited me about going into that opportunity. I think what it has struck me though is, and it shows, is that the system of Wales has been like this since 2009. But have we really exploited the opportunities that having all those things in one place brings? Probably not, if I'm honest. I think because the organisations are such big scale operations, so my organisation's £1.3 billion organisation, 14,000 staff, 40 odd sites across a geography. So it's a big beast of an organisation to oversee and lead. But I don't think we've necessarily maximised those potential opportunities. So to your earlier point, it's not just about having everything in one place that makes it suddenly integrated, right? It's about how you drive and bring together those clinical teams, and also set an expectation of how you want to do it. And I think historically, people are quite used to working in silos, aren't they? If you were somebody managing a primary care practice, you're pretty much flat out day-to-day running GP practice. And yeah, you can see that there's things that need to change around you, but actually you haven't got the capacity to really step out of your day job and get involved in that and start to think about how you shift the balance of power, if you like, between primary and secondary care. Likewise, if you're a busy ED consultant and you see all the stuff coming through your front door and you know that really it probably shouldn't be coming in, because you don't feel you've got the influence of how you can shape and change the way in which you've done things. So one of the things I feel that I've done through my career is try and get those clinical teams, get alongside those clinical teams, talk to them about not working well, and seeing my job as the person who tries to create the environment in which they can then come together and make some of the changes they want to do. So when I started in Somerset, for example, pretty unusually, I think, for an acute hospital chief exec, I went around every single GP practice in my patch and met all the GPs and spoke to them individually about what they thought the issues were with the hospital. And frankly, you go through all the usual, well, the discharge summaries are rubbish, and you send out these people who don't need this, that, and the other, and you ask yes people. And I said, right, okay, I can take that. We'll deal with all that operations stuff. But once we've dealt with that, what could we do to build the relationship between primary care and secondary care? Because you're all telling me that, these people don't need to be in hospital. So what are we going to do differently together to work on that? So that's where the Symphony program was really evolved from. So I do honestly think, Matthew, a lot of this comes down to leadership, and it comes down to vision and a willingness to challenge the norms. Because I think we work in a world where, if you're an acute hospital chief executive, your job is to run the acute hospital. That's what you're managed on. That's what you're incentivized on. That's what your performance managed on. I think ICSs are bringing people much more into the wider integration space, and there's more of a collective responsibility. But let's be honest, if you're a big, large FT working in an ICS, and then someone's going to tell you you're going to have to shift all this work out, and you're going to, your ambition to have a nice brand new, big, shiny hospital might not be quite as valid as it once was a few years ago. Are you going to say, oh yeah, that sounds a great idea? And people might say they would, but in reality, is that actually going to change? So I think maybe it's that ethos, it's that vision, it's the leadership, but it's also the willingness to want to cede some element of control to things. That's difficult for leaders often to say, okay, I'll give that up and hand that over to someone else to take responsibility for, because they're probably better placed than I am to run that. And I think that is a really difficult thing. I think people haven't got into these jobs historically from just being passive. They've been, my view is, if you get to be a chief executive, you're probably quite a competitive person who wants to be successful. And so therefore we're then surprised when we put a group of chief executives in the room and expect them to suddenly all work together and collaborate and perform and agree that the collective benefit is greater than the individual benefit. So I'm perhaps being a bit harsh there, but I think it is about leadership. I think fundamentally all this comes back to at every level, chief exec level, executive level, clinical leadership level, ward manager level, GP practice manager level. It's all about people being aligned towards the same common purpose and challenging each other about where they feel those barriers are happening that prevent them doing what they want to do.
Yeah, so Paul, I completely agree. And I think that this is something that I come to again and again in these kinds of conversations. which is that we talk about all sorts of things and then we come back to leadership. The problem is that then leadership starts to feel like a kind of black box. It feels like, well, it boils down to this thing, but it's a thing which is hard to understand. Where does leadership come from? How do you summon it up if it isn't there? And I think that we don't sufficiently recognize the vital importance of putting the time in to build a culture of leadership. I think we know quite a lot about organizational leadership. I'm not sure we always get it right. I think sometimes we can be a bit mechanical when we think about it. But we know much less about system leadership. The Confed has put together a system improvement program with Q Network at the Health Foundation. And part of the reason we've done that is because we think that leadership in system, in place, collaborative leadership necessary for integration does involve a different kind of set of skills. And I think trying to get into that black box so that we don't simply say, well, it's down to leadership and trust. And people go, well, great. But where is this leadership and trust? Where do I buy it from? We have to do the hard work of saying, actually, there are ways in which you do this. So, for example, I've come to this kind of, it's very trite, I'm afraid, but this kind of journey that I think sectors within the health service locally need to go through, which is from irritation to integration to innovation. So let me explain briefly that, you go to anywhere and the first thing you'll hear when you talk to the acutes is how they feel let down by primary or by social care or by the ICS or whatever. When you talk to the ambulances, they'll talk about how terrible things that emergency departments do to them. I'm afraid blame is really very high up our narrative in the NHS in a way which is actually slightly unusual. If you go to leaders in other sectors, blaming other people is not really considered to be a very good leadership trait. But, we turn to it pretty quickly in the NHS. So first of all, you've got to go to that pain. We're doing some work in the Confed about the primary-secondary interface. You just got to start off by saying, okay, look, come on. How are we really annoying each other, irritating each other? Let's put that on the table. And then if you do the work there, generally you will find that actually there are relatively straightforward ways of overcoming those irritations. Yeah. Then the next step is to say, okay, what can we do to kind of bring things together a bit better? The ideas we've been talking about, Paul, which is let's just try to streamline things a bit better. Let's try to make things lock together a little bit better. And then the final bit, the kind of transcendent bit, is when you go, well, actually, now we've stopped annoying each other. Now we've started kind of getting things aligned. Suddenly, the possibility of doing things differently occurs. Now, the point I want to make here, Paul, and sorry me going on at such length, is you can't get to the innovation piece unless you do the hard work of getting through the irritation piece. So you get a group of people in the room who annoy each other day to day and say, how are we going to do things differently? It's a complete and utter waste of time.
Yeah. No, I agree absolutely. And it goes back to my point about what integration is not. It's not an organisation structure. Because if you think by bolting bits of a frankly dysfunctional or irritated system together, it's suddenly going to be a magic wand that's going to suddenly make everybody say, oh, great, we'll all work together now because we'll work under this integrated system. It's not going to work. And I think I absolutely agree with your sort of three levels there. Because until you sort out the sort of the day-to-day stuff that is getting in the way of people working together, you won't be able to move on to an integration journey. So, I remember back to my days working in Torbay when we were bringing together health and social care, historically massive discord between if only the bloody social teams, social services people would do this, we'd get everyone out of hospital quicker, and they'd be saying, well, if only health wasn't sort of thinking everybody needed a medical model of thing, when actually it's all about the social model. And actually, until you get those people together and talking about it, and I remember one of the things we did when we did that bit of work in Torbay was we had everyone in the room together. We had GPs, social workers, community nurses, everyone. And we said, right, okay, so take a scenario that somebody needs packaged domiciliary care. GP has identified that need, and we literally lined up the number of people that would be required to get that package of care set up in the room. So you had the GP at one end would see the need, and you had the dom care manager or worker at the other end who was a person delivering the care. 12 people we calculated were needed. And we said, right, our ambition is to shrink that so that the GP could speak to one person, describe the issue, and the care is set up. And that's where we got to. But all those steps in their 12-people journey were irritations that people had to refer someone on. They didn't meet a criteria, so they got bounced onto somebody else. And all that stuff is what really, really bugs someone clinical professionals, because they can see what needs to happen for the individual, but we've put in this bureaucratic process around them that said, oh, well, if it's a Wednesday and it's 3:30, that person can't be seen by nurse X because they don't do that. Or, sorry, you don't meet the criteria for this service, you'll have to phone this number. And it's not just frustrating for the professionals, or if you think it's frustrating for the professionals, imagine how bloody frustrating it is for the patient and their family, who are then trying to navigate their way through that system and not knowing who they're going to or who they speak to. So you're absolutely right. Until you sort some of the day-to-day stuff that is bothering people, you're not then going to get them together to think about, right, well, actually, what could we do strategically to redesign this system to make it more efficient, more patient-centered? And then, as you rightly say, and once you start to get those people working together, having shared objectives, shared ambition, shared understanding of what they're trying to do, suddenly they start saying, oh, I don't know what, we could probably do that really differently or innovate. Or why are we even doing that process in the first place manually? Let's bring in a digital solution that enables us to do that differently. Or let's, I don't know, do something, redesign the service completely from top to bottom. But they've got a shared understanding. They know each other. They understand each other. Frankly, the biggest impact I think we're going to obey of integrating nurse and surgical care with bringing them in the same room together and sitting them as in an office together. So you have social workers, nurses, physios, OTs, all in one big space in a locality, and their job was to run and look after that population of people. And hey presto, suddenly the social worker said, oh, I didn't know you were dealing with Mrs. Jones. I just heard you talking about that. And they'd suddenly have a conversation and say, oh, actually, if you're going out this afternoon, I don't need to bother going, because could you just take that walking aid that she needs rather than sending out the OT a bit? And it was unbelievable just how some of those simple, basic stuff would bring people to, and we overthink this, right? We over specify, we over design it. And actually, this is about just people working together, doing the right thing for the population. And our job as leaders, surely, is to create the architecture around them that enables that to happen, whether it's physical architecture, whether it's digital infrastructure, whether it's governance structures and, say, working processes or HR policies, whatever. But I think we get so preoccupied with the design of this thing, we don't pay attention to all that other stuff that is so, so important on a day-to-day basis.
Yeah, absolutely, Paul. And I think that part of this is also about recognizing that the barriers we're requiring people to overcome are big barriers. I think sometimes we talk about failure to integrate as if, why are we not doing this really obvious and simple thing? But actually, the logic of organizations, so if you're a patient, the world is made up of organizations with porous boundaries because you're going from one organization to another organization. But if you run an organization, there are the things you control, and then there's hard walls beyond that things that you don't control. So the way we work in organizations gives us a picture of the world, which is very different to the kind of principles of integration. You've then got, professional defensiveness and professional boundaries, particularly an issue, amongst clinicians. We did have in England in particular that competitive mindset, which didn't help us at all. And, organizational leaders, I'm very competitive. Organizational leaders are competitive. So when you have a government that encourages even more of that, now I think we suffer from a scarcity mindset. And I think when there's this feeling of inadequacy and scarcity and we can't achieve what we want to achieve, then kind of blame, defensiveness, risk aversion, all these things come to the forefront. So I think when we work with our colleagues around these challenges, we have to acknowledge we're asking them to do something, pretty difficult. But if we don't do it, we're never going to get out of the place we are. Now, Paul, I don't want to end up without asking you about innovation, and we've almost run out of time, so I've not got this interview absolutely right. We'll have to get you back on Health on the Line. But innovation's been a key part of your career. Let's just end by, can you pick something that you're doing in Wales at the moment, which is innovative and that you're particularly excited by? I'd love to hear an example from you.
One of the things we are doing, which I think is, so we've got a really good structure now in our health board where we have what we call a navigation hub. So it's run by GPs and other professionals in the community, supports the out-of-hours GP service, so out-of-hours, but in-hours is also available to support admission avoidance. So we've now added to that team with OT, paramedics, nurses, And going back to my earlier point about how do we design a better model about hospital care, I'm really excited to think about how that model could start to be expanded into looking at urgent on-the-day primary care demand. We talk to nursing homes about whether that sort of navigation hub becomes their first port of call for any problems or concerns they've got about an individual in their care, to avoid them phoning 999 and sending the person from the hospital. There's a whole heap of work we can do with advanced care planning to make sure that those patients in our communities who don't need to be taken to hospital have got that clearly described and written in. So it doesn't sound super exciting or super innovative, probably, to many people listening, because we've probably got that in other parts of the UK. But in our patch, we have never had anything like that. And it's beginning to have some really positive impact on a lot of our population in our communities to avoid them being taken to hospital. So that's something for me which is really exciting. And then underpinning that also is the work we're doing on population health management in our patch. Because we have public health in the health board, which is really positive, we've got a single data set now that identifies and segments our whole population, which enables us to then also start to look at how we can use things like our navigation hub as a proactive care coordination centre to actually contact proactively those patients that are the most risky segments of our population to try and avoid them deteriorating further, picking up any issues early doors, of intervening earlier to try and avoid deterioration. So I guess it's a piece of work around the whole management of our population, which for a population that we look after, which is a very deprived population, some of the worst health outcomes anywhere in the UK, it feels really, really important to do. So that for me is a really exciting, innovative piece of work that I think has some good potential to really make an impact in our communities.
Which leads to very, very final question, Paul. And again, I'll have to ask you to be reasonably concise about this. But data, digital, what is its potential in relation to accelerating some of the things that we've been talking about in terms particularly better integration built around individuals?
It's better to come back to my earlier point, Matthew, about if we want to segment our population and design services around the population, we've got to know what's the population we're actually talking about. And the only way you can understand that is by looking at the data. And what does that tell you? And that's data that brings together primary care, community services, ambulance data, hospital data, prescribing data. That's exactly what our Symphony data set did in Somerset. And it was the data that drove the design of the care models that designed the model of integration that we implemented in Somerset. And I think if you try and do this without data to help design the model, you're basically going to be doing it on the back of individual clinical perspectives or opinions, which I'm not saying are wrong, but in any other industry, the first thing you do would be to look at what's the data telling us and what do we need to do to use the data to design the way we deliver services. And also, how do we use the data then or change something to measure the impact it's had and understand if it's delivered certain things that we want to do. Because what we're probably pretty terrible at in the NHS is actually evaluating, did the thing we implemented actually have the impact we said it was? And if it hasn't had the impact, we should stop it and refine it and redesign it. And I just don't think we use data and information to drive how we design and reshape and refine our services. We tend to do a whole heap of work, get excited about it. It might have some good impact, it might not. And then we move on to the next thing. Because that's the latest initiative that's come down or the latest ask that's come to us from somebody else. And I think we've got to get much more robust at using data and information to drive everything we do across the whole of the NHS.
Well, Paul, I've been looking forward to this conversation, and it's absolutely lived up to my hopes and expectations. Thank you so much for joining me on Health on the Line.
Thanks very much to you, Matthew.
And thank you all for listening. This episode of Health on the Line has been supported by Novartis. If you enjoy Health on the Line, why don't you leave a rating or a review in wherever it is you get your podcasts? It really does make a difference. But until next time, goodbye.
You've been listening to Health on the Line from the NHS Confederation. Visit nhsconfed.org for more information about us and to register for events and webinars that delve deeper into the issues explored in this podcast.